are still the same. It's just how we do it is now, you know, a true treatment. It's not something that you just saw that was almost inhumane as far as what they did. Now, what you guys need to understand is these are not, my patients were not like, you know, what you see at the VA or at LifeShare or anywhere in your lives or families or friends as far as major depressive disorder. My patients were at the point of despair. Their pain was so severe, they often came with repeated attempts at suicide. My patients generally would go for the radial artery. I had some that would try to cut the carotid and some that would try to cut the femoral arteries to kill themselves. My patients would drink things such as gasoline. They would swallow things such as spoons because of that despair and intense pain that they were feeling from a psychological standpoint, okay? I had one man that cut his tongue after slashing his wrist. A cut right here. Because these patients, again, are at the end of their, they have no hope, guys. These are patients that you need to know are treatment resistant. They have had every other kind of treatment possible. The patients' charts that I took care of were this thick because they had tried everything to try and help these people. So they are treatment resistant. You will find, and I'll show you that, or you can read this. I found what a patient said about ECT therapy, and it really highlighted what I wanted you to walk away with about ECT therapy. That if this treatment can give someone hope, are you okay with it? No matter how barbaric it may sound and seem? Because these are the patients you're dealing with now. A lot of my patients have family histories of suicide, substance and alcohol abuse, and I had all ages, from 16 to 80, 85. A sense of hopelessness. They feel like there's nothing to live for. A lot of them are non-functioning. We often would refer to that as being vegetative. A lot of them didn't eat. A lot of them didn't sleep. They just sat there or laid there. They couldn't work. They couldn't interact with family. They couldn't socialize. So you can imagine, guys, some of my patients, their families did what? Gave up on them. They disowned them. Okay? Several of my patients, it was a neighbor or a dear friend that stayed with them because the family had disowned them. They gave up. So these patients, again, this is their last chance at treatment that may give them relief from pain, psychological pain, and hopefully give them some form of life and hope. Does ECT work? Yes, it does. Okay, it does. So I just want you to remember that these are the patients you're dealing with. They have gone through every type of treatment possible. Okay? So that's the type of patient you're dealing with. Now, I also put in here, let me show you. What's that thing? And this is to give you a visual. Obviously, I can't give you a visual. It was the closest I could find to what ECT therapy looks sort of like today. Okay? So that's what I'm going to show you now. Is it up? Okay.
ECT is a powerful way to treat severe depression, but it is used only when traditional medication approaches have failed.
Just look at me.
Is that too loud?
What about you look different? Everything I smell.
What it kind of looks like, okay? So again, when we look at when we look at nursing care, what I have done is I have actually gone through and given you it'll come up. A more detailed information of how this is actually done, okay? First of all, to let you know, guys, these patients have to be cleared with a physical and psychiatric exam, okay? Why? Well, you know, we are going to send currents through to the brain. So they have to have a physical and exam, okay, prior to treatment. So we don't just say, okay, this patient, we've tried everything, so let's just, you know, take them on in for ECT. It is required consent, and this can be, doesn't have to be the patient. Okay, so you've already seen in sight that our patients can be voluntarily or involuntarily committed. So if it was involuntarily, someone else can sign consent for this patient, okay, to have this treatment done. Of course, this is in a very controlled environment, okay? We had a room, and we're in the recovery room, okay? And, you know, I want you to know that, yes, it's still controversial, but it is done in a safe environment, okay? Of course, an IV is started. Also, I put in there to let you know that if I'm in the room, I have to check the emergency equipment. You know, that was part of my responsibility to make sure that all emergency equipment have been checked, everything's within date. Suction is working so that just in case if something happened, then that's readily available, okay? And what we did is we normally put in normal saline. My patients could either come from upstairs, from the inpatient psych area, or they came from outside as an outpatient. In fact, a lot of my patients were outpatients, okay? My patients we wanted them NPO since midnight. That's because we are going to use anesthesia, just like if you were going for some type of minor surgical treatment, okay? I forgot my little thing. Okay, now like I said, my patients had to have someone with them, right, if they're outpatient, because some of them are going home, some may be at an outpatient facility or clinic, others we sent up to the inpatient psych area, okay? Now, like you saw in that room, guys, there's anesthesia or CRNA, of course a psychiatrist is there, and a nurse, okay? And to let you know, there was a time when ECT was, I don't know, you know, how do you say popular? Zapping somebody's brain. But we did a lot. I mean, I could average 10 patients on Monday, Wednesday, Friday mornings. Okay, my patients came in at 6:30. They were first on the cases, okay? They came in at 6:30, and most of my patients were gone. I was done by noon, okay, with ECT stuff. And then it became less used as controversy still continues to be out there, okay? Why? Why do you think this is such a controversial issue? Okay, it looks inhumane. Okay, a lot of people, that's the biggie I want you to walk away with. A lot of people do not understand how intense psychological pain can be. Okay? Has anyone in here ever known somebody that's had suicidal ideation or tried to commit suicide? Okay, then you have a better understanding of what someone can feel. Because there are some people that are like, you know, there's the typical. What do we always hear? They're crazy. They're just crazy. And that philosophy, guys, as you can see, goes back to the old days of when a majority of people considered mentally ill as it's something with you, right? It's your genes. It's because you're messed up in the head. And we don't want to tolerate it. Because we're normal. Like I'm normal. It's a joke. So, again, you know, we've come a long way. But this type of treatment is still out there. It is still controversial. I'm going to tell you. There's no ifs, ands, buts about it. But it has shown success with a lot of patients. Of course, a lot of my patients, the primary diagnosis was severe depression. But we did see some patients that were, of course, bipolar, schizophrenic, or a combination of both. But the majority were severe depression. I want you to know, though, that, again, even though it looks inhumane, it truly, once you identify with the patient, you can see why this is so important to have something like this. Now, guys, I'll tell you, there's the transcranial magnetic stimulation, okay? That does not induce a seizure. Well, just to let you know, a lot of my patients had already tried that. You know, I'm telling you, this is the last resort of trying to find something that works, okay? It's no different than if somebody gives your family member, this is how I look at it, gives your family member a diagnosis, And you know the doctor says, this is the one last thing I think we can try. What are you going to do? You're going to try. You're going to go for it, okay? So it's kind of, you'll use that analogy. It sometimes helps you to understand. Our patients are monitored with EKG, blood pressure, and O2 sats, of course. Now, electrodes. Yes, the electrodes are placed on their right here. Usually, they apply electrodes, what we call bilaterally, okay, for both sides of the brain, for those impulses. There are times, but it was rare, when they would just apply it's called unilaterally. Majority that I saw were bilaterally, okay? Again, what we are doing is we are actually going to generate impulses, and yes, we're causing a seizure. There's no other way to describe it. We are causing a seizure. All over the place, aren't it? Okay, so bottom line, we are inducing a seizure. So the best way for you to think about care of this patient is think about the patient post-ictal. Does everybody know what post-ictal means? What does that mean?
They get seizures in 3 weeks. So no, they probably don't.
Okay, post-ictal, and think of it as post-seizure. Post-seizure activity. It's just with this patient, we have actually induced. We are inducing the seizure, okay? Now, some of you may be asking, why is there a blood pressure cuff on the lower extremity? Okay? What they do, you've got your IV, you've got your CRNA, you've got your psychiatrist who comes flying in at the last minute, obviously. Okay? And once the CRNA starts the anesthesia, then we give anesthesia. Could be with gas or it could be IV, either or, okay, whichever they decide. Then we give a muscle relaxant. It's called succinylcholine. Sometimes we gave Robenol. That just dries up secretions. That's all it does, okay? Once the patient is sedated, once I saw the succinylcholine, to let you know, just clinically, oftentimes they would give caffeine to make the seizure last longer. Okay? Actually give them caffeine to make it last longer. Once this was going in, anesthesia will put in the oral airway, obviously, so they don't hurt their teeth or mouth area. Then I would pump up that blood pressure cuff to like 200. Okay? Why? That patient is not going to have, how do I say this? Grand mal effects such as injuries. Does that make sense? Because we are sedating them, because they've got a muscle relaxant, they're not going to be doing, I want you to get that picture out of your brain of this. Okay, they're very still. Okay, so it's not this, what you saw from the previous, okay? Because of that, they're not going to do that, guys. They're not going to have that violent up and down repetitive motion because of those medications. Now, why did I pump it up? Because I've got to time the actual seizure. How did I do that? I pump up that blood pressure cuff before the psychiatrist hits the button, right? Because right after all that, The psychiatrist is going to hit the button. That's going to deliver a very minimal, it's low voltage, so I don't want you to sit here thinking we're defibrillating the brain. You know, it's low voltage impulses, okay? And once they hit it, I have to time that seizure. And what I'm doing is I'm monitoring that big toe as they quiver like this. So you don't have that violent nonsense, inhumane stuff. It's just the actual quivering of that lower extremity where that blood pressure cuff is, okay? And that's because I don't get all that muscle relaxation and stuff going in there. So I actually monitor that. You want at least 25 to 30 seconds to get effective treatment, okay? The theory behind ECT, guys, again, is that by generating that seizure, a seizure is abnormal electrical impulses to the brain. By generating those impulses, we somehow either change how our neurotransmitters work, such as serotonin, norepinephrine, dopamine. You know, we somehow change that so that their mood can turn around, okay? I saw my patients generally Monday, Wednesday, Friday for about 3 to 4 weeks. Okay, Monday, Wednesday, Friday, 3 to 4 weeks. At the end of that, if they were doing better, then I may only see them once a week, okay? And then some of mine even went to once a month. Now, guys, I can't tell you that the importance, remember all that pharmacology we talked about? Okay, they have to take medications to try and prevent relapses, okay? Relapses, okay? So those pharmacology meds are also added to their treatment regimen, okay? Some of my patients wanted it was advised to them, come back once a month. Come back, get your shot. Come back. And some of them, again, guys, I saw an 85-year-old go from a tunded fetus position to this with ECT therapy. I saw a young man who had lost everything, his job, everything. He came back, he got back with his wife, he was working, he had hope, he had self-esteem, he had what now was a life without pain. And I know that's hard for a lot of us to really understand. How can psychological pain be so painful? But I'm hoping with your clinicals that you've learned how painful it can be for these people, okay? Take a break, because I see you going, take me that long, so I know everybody wants to get out of here. After a test, I know, you don't tell me, I've been doing this too long. Yeah. Too long. So, nursing care, though, this is something that, if you didn't pay attention before, pay attention now. Okay, again, you want to think of nursing care after a seizure, okay? And guys, one thing I will tell you is that if your patient has just had a seizure, whether it's induced or it's for another type of reason, these patients are, again, very drowsy. Sometimes there's confusion. I generally did not have too many problems with them trying to get out of the bed or anything like that. Most of them were just very, very sleepy and confused, okay? Now, think about it. We just induced electrical impulses to the brain. Do I want to stimulate my patient now?
No.
No, let them sleep. Let them just wake up on their own. We don't give them anything to wake up. We just let them wake up on their own, okay? Usually that doesn't take that long. Majority of my patients within 20 to 30 minutes were much more awake and ready to go wherever their destination was at that time. So again, let them sleep. Know they're going to be confused. Don't produce a lot of stimulation right after they come out. Vital signs are taken, of course. In the real world, if you want to know, it was every 10 minutes and then every 30 if needed. Again, mainly looking to make sure heart rates were not elevated, blood pressures were not extremely elevated. If they were, then they would have to stay there with me and get meds to help treat their cardiac issues. But those are the more common side effects. This one, your theory says temporary memory loss. Again, being in the inpatient setting, I did have some of my patients say they still had memory loss, but the psychiatrist said that that is truly rare, that most memory loss is temporary. However, you know, memory loss could continue for a longer period of time. You just have to reassure the patient that that is normal after an ECT. Memory loss is normal, okay? Again, we've already, that's what makes this nice, short and sweet. We've already talked about the meds. So you guys know that they're going to be taking the meds, the antidepressants. Again, all of this to prevent relapse, okay? Now, last, to give you a better indication of how ECT can help our patients, or my patients that I took care of. This I found from one of the sites, like about.com or something, whatever. But again, and I know you guys can read and don't need me to read, but again, this is a young man, 26, developed severe depression and anxiety, and he didn't fit the picture. He had a Bachelor of Arts in Psychology, who's happily married, and a lot of my patients, of course, have families too, so I don't want you to think it's somebody off the street. Okay? Okay. This patient, again, showing the typical signs of depression. And basically not coping, okay? Ineffective coping. So, he went to a psychiatric hospital. He started on medication. And unlike our patients who mood changes, which is what you hope, his did not. And they approached him about ECT. And this is something that's very important. This is not for everybody. And this is something the psychiatrist reemphasizes to the patient. This is not a cure, okay? It is an option for patients who are treatment resistant, okay? It can't cure your mental health disorder. The patient was explained what I just went over about how it is conducted in a safe environment and that you're monitored while this is going on. Again, my patients do not complain of pain when they wake up, because that was like my concern as a nurse, that they're not in pain. Does that make sense? I mean, you know, we're inducing a seizure. You know, I want to make sure you're not in pain. They never complained of pain. And in fact, most said they didn't even remember what had happened when they were down there with me. That was just like a fog, you know. Again, temporary confusion, memory loss, some headache, but nothing major. Most are sleepy and just want to sleep. Again, there are risks, as with any type of procedure. You guys already know that. I mean, with any, who was it? Kanye West, mom getting a tummy tuck or something, and she's dead. I mean, there's risks with everything, guys. So I don't want to make it sound like this is. But this is what a lot of patients, again, this has saved my life. It has given me hope. And for this patient, he went into the mental health field and is continuing on with his life. And that's really what it's about. I thought this was interesting, that there is hope. And again, I think what he was saying is we're not crazy. We're not this diagnosis. We are people that want a life. And when they're in that kind of pain, there's like no light shining, guys. I mean, like I said, I've seen patients come in the fetal position, won't talk to me, won't look at me, nothing. And then my little 85-year-old. I'm back. So, do you have any questions? Very light, not a lot of reading. You want to get out of here? I'll see you next Wednesday, guys, okay? I'll see my, oh.